Hello, everyone, and welcome back to the EP Edge podcast. This is Dr. Niraj Sharma bringing you the November 2025 edition, issue number 6. Today, we take a step back before we look ahead. Atrial fibrillation ablation has traveled an extraordinary road over the last 3 decades, a story of innovation, persistence, and yes, occasional frustration. Let's begin with where it all started. In the late 1980s and early 1990s, Dr. James Cox introduced the Cox Maze procedure, a surgical solution that literally created a maze of atrial incisions to block errant electrical wavefronts. It was elegant, logical, and remarkably effective, but it required open heart surgery. The concept, though, laid the foundation for everything that followed. If you could isolate or interrupt the circuits, you could restore rhythm. Then came a paradigm-shifting observation from Dr. Haïssaguerre and colleagues in 1998. Their landmark paper identified pulmonary vein ectopy as the trigger of paroxysmal atrial fibrillation, a discovery that revolutionized our approach. The goal was no longer to carve surgical mazes, but to electrically isolate the pulmonary veins through catheter ablation. Soon after, Dr. Pappone and others advanced the technique with wide circumferential pulmonary vein isolation, ushering in the modern era of catheter ablation, guided by electroanatomic mapping, improved catheters, and real-time imaging. Over time, our tools changed dramatically. Radiofrequency ablation dominated the early years, precise but unforgiving. Then came cryoablation, offering the simplicity of a single-shot freeze and improved reproducibility. And now, we stand at the threshold of pulse field ablation, a non-thermal, tissue-selective technology that promises safety and speed never seen before. But here's the paradox. While our energy sources have evolved, the long-term success rates of atrial fibrillation ablation have not improved as much as we'd hoped. We've made enormous strides in safety, with lower rates of tamponade, stroke, and pulmonary vein stenosis, but durable rhythm control remains elusive for many, and that realization has shifted our focus. We now recognize that atrial fibrillation isn't just an electrical disorder, it's a disease of the atrial substrate. Behind every recurrence lies an evolving story of atrial myopathy, fibrosis, inflammation, and remodeling. Emerging biomarkers from high-sensitivity CRP to galectin-3, transforming growth factor beta, and natriuretic peptides help us understand this biology, though they add little incremental predictive power beyond what we already know clinically. Advanced MRI and electroanatomic imaging now allow us to see the atrial fibrosis that once was invisible. So as we move into this month's discussion, we ask, when atrial fibrillation ablation fails, have we truly reached the limit, or are we simply targeting the wrong substrate? That's where today's EP Edge newsletter begins. Stay with me as we explore why ablation fails, what lies beyond the pulmonary veins, and where the next frontier of rhythm control may take us. This is Dr. Niraj Sharma, and you're listening to the EP Edge podcast. Now, let's dive in.
Okay, so let's unpack this deep dive into atrial fibrillation, AF catheter ablation. You know, it's really pushed towards being a first-line therapy lately. But our sources are pointing out something kind of perplexing. We've got amazing tech, RF, cryo, PFA, but the success rates seem to have just stalled.
That's exactly right.
Yeah.
It's what the research is calling a biological ceiling. You look at 1 year freedom from AF, even with the latest tools, it's stuck. Maybe 60, 75%.
And long term?
Well, that's where it gets really concerning. 5 years out, you can see success rates dipping below 40% sometimes. So the issue isn't really the catheter, it's the biology we're up against.
So pulmonary vein isolation, PVI, it's a necessary step, but clearly not the whole picture.
Not the whole picture at all.
Our mission here then is to figure out why that ceiling exists, what's holding us back, and what's next beyond just creating lesions.
Right. So when ablation fails, it's usually more complex than just a simple electrical short circuit reappearing. Yeah, the most common trigger we see is late reconnection of those pulmonary veins.
Yeah.
That definitely happens maybe 20 to 40% of the time. But those reconnections, they're often just exploiting a deeper problem.
Okay, let's zero in on that deeper problem. The structural remodeling. People usually think fibrosis, scar tissue, but the sources flag something else too, something infiltrating.
Yeah, periatrial fat.
Yeah.
Fat tissue around the atrium. It doesn't just sit there. It gets into the muscle. It's inflammatory. It actively helps keep the AF going. Think of it like biological kindling around the heart's chambers.
Wow. Okay, so it's not just fixing faulty wiring. It's like the foundation itself is compromised.
Exactly. That fat and the atrial enlargement that often comes with it, they are strong predictors that AF will come back.
That's true.
The data suggests that for every, say, 10 cubic centimeters increase in that fat around the left atrium, your risk of recurrence goes up by about 10%.
Mm-hmm.
It's significant. We need to look at the structure, not just the electricity.
So if that biology, that substrate, is the real driver of failure, what are the warning signs clinicians see? What tells them, uh-oh, this one might be tough?
Well, the biggest red flag, according to the sources, is early recurrence. If AF comes back quickly, say within the first 2 months after the ablation.
That soon?
Yeah, that soon. It's the strongest predictor of late failure down the road. Makes future failure about 3 times more likely.
Okay, that's a clear marker. Are there others?
Absolutely. Things like having persistent AF, the kind that doesn't stop on its own, that bumps up the risk maybe 1.7 times, and then the usual suspects. Obesity, diabetes, being older, say over 70, these all play a role.
This really brings us to that paradigm shift, doesn't it? The core idea that the disease isn't fundamentally the vein, it's the atrium itself. Atrial myopathy.
Precisely. And we can actually see it now with advanced imaging. LGE MRI scans can map out fibrosis, the scarring in the left atrium.
And what does that show?
It shows that once that scarring covers about 30% or more of the atrial wall, the chance of AF coming back jumps over 50%. It's stark. We spent years perfecting tools to zap electrical triggers.
Right.
While maybe ignoring the underlying mechanical issues, the metabolism, the inflammation that was really driving the bus.
Okay, so if we've hit a biological ceiling, the treatment has to evolve. Moving away from just lesion creation towards disease modification, what does that look like in practice?
It's got to be multimodal.
Right.
A combined approach. First off, serious risk factor modification.
Like diet and exercise.
And more. Intensive weight loss, treating sleep apnea aggressively, tight blood pressure control. Studies like ARREST AF actually show this can reverse some of the structural damage. You have to clean up the biological environment.
Makes sense. So that's step one. What's step two? Bringing that biology into the procedure itself.
Exactly. Precision ablation. Using those LGE MRI fibrosis maps during planning. So instead of a standard PDI pattern for everyone, you customize the ablation. You target the specific areas of scar tissue known to cause problems.
Tailoring the treatment. And the third piece, pharmacology. Are there new drugs coming into play?
Yeah, that's a really exciting area. Exploring agents like GLP-1 agonists, SGLT2 inhibitors, drugs you might know from diabetes or weight loss.
Right.
They aren't traditional heart rhythm drugs, but they seem to tackle the metabolic side, the inflammation, the fat. They might reduce AF burden just by making the atrium healthier overall, working alongside the ablation.
So putting it all together, the big takeaway here for you, the listener, seems to be ablation works best when the atrium is healthiest to begin with. Recurrence is basically fibrosis plus fat plus inflammation plus time.
That's the equation we're dealing with. Yeah. And it really suggests the next big leap forward in treating AF probably won't be a slightly different catheter, hotter, colder, faster pulses. It's going to come from truly understanding the biology and shifting to this comprehensive multimodal management, restoring atrial health.
And that really challenges the traditional focus, which was heavily on the procedure itself. Which leads to, I guess, a final provocative thought. If future success depends so much on restoring atrial health, how much of the effective therapy needs to happen before a patient even steps into the EP lab?
And that brings us to the end of this month's EP Edge newsletter, November 2025, issue number 6. Today, we walked through the fascinating evolution of atrial fibrillation management, from the surgical Cox Maze procedure to the discovery of pulmonary vein ectopy, that reshaped our entire approach to rhythm control. We traced how Haïssaguerre's seminal insight opened the door to catheter ablation, how Pappone's wide circumferential lesions redefined procedural strategy, and how energy sources evolved from radiofrequency to cryo and now to pulse field ablation. Yet, as we've seen, despite new tools and new technologies, the ultimate success of ablation remains tied not just to our catheters or energy sources, but to the substrate we're treating. Atrial myopathy, fibrosis, inflammation, these are not simply bystanders, but active participants in arrhythmia, persistence, and recurrence. Today's discussion reminded us that the future of AF therapy won't hinge solely on better ablation lines. It will depend on understanding the biology beneath the rhythm, the molecular signatures, the imaging correlates, and the interplay between inflammation, fibrosis, and electrical remodeling. As we look ahead, the next frontier lies in integrating these insights, combining precision electrophysiology with precision biology. Tools like AI-driven mapping, tissue-specific imaging, and biomarker-guided therapy may help us move from ablating triggers to reversing disease. The story of AF isn't finished, it's simply entering its next chapter. Thank you for joining me on this journey. For infographics, data sources, and full references, visit the EP Edge LinkedIn newsletter. If you have any questions, feedback, or suggestions, I'd love to hear from you. Just email me at epedgecast@gmail.com. And don't forget to subscribe, share, and follow the EP Edge podcast wherever you listen. Till next time, this is Dr. Niraj Sharma signing off. Take care and bye for now.